Hi, I am Dr. Sunil Kumar. I am a fetal radiologist. I have been practicing fetal radiology since 15 years. In this class, I am going to present about prenatal screening, that is, screening in pregnancy. So let me quickly share the screen. All right. So prenatal screening, a simplified approach to understand the basics and beyond. Why this topic is important? So when we do ultrasound scanning, you may be surprised to know that out of 100 scans, 50 to 60 scans would be pregnancy scans. So most of the time, pregnancy or obstetric scans comprises the majority of the scan in everyday practice, not only in India, in the entire world. And coming to the commonality of pregnancy, in India, according to latest census, for every 1,000 people, 17.1 is the birth rate. And for every 2 seconds, a baby is born. If we look at the bigger picture, in the entire world, 3.85 lakh, that is 3,85,000 babies are born each day. So it is very important to know what exactly is prenatal screening. And in my practice, what I have observed is lot many doctors who deal with pregnancy, they could be seeing their patient. There is lack of clarity in understanding what exactly this prenatal screening is. So today I am going to simplify the approach for prenatal screening. So let us begin this class. So what I have done is, this presentation I have divided into 4 steps so that it can be easily understood. So it's a stepwise approach to detect fetal chromosomal abnormalities in pregnancy. In step 1, we are going to understand the common fetal chromosomal abnormalities and their impact on the life of the baby and the parents as well as to the society. In step 2, we are going to understand the various prenatal tests to detect chromosomal abnormalities. In step 3, we are going to understand the basics of prenatal tests, interpretation of results, and counseling. In step 4, we are going to understand how ultrasound is going to help to detect these chromosomal abnormalities in first trimester pregnancy. So let's begin the class. So in step 1, let us know what are the common chromosomal abnormalities at birth. So the most common chromosomal abnormalities are trisomy 21, that's called as a Down syndrome, which occurs at a rate of 1 in 650 to 800 birth. Next is trisomy 18, it's called as Edwards syndrome, which happens at 1 in 3000 to 6000 birth. And trisomy 13, which is called as Patau syndrome, which occurs at 1 in 7000 to 10,000. So these 3 chromosomal abnormalities, trisomy 21, 18, 13, they comprises 95% of fetal chromosomal abnormalities. The other common abnormalities are monosomy X, it's known as Turner syndrome, then triploidy, otherwise then we have XXY or XXX syndrome. So these 6 chromosomal abnormalities constitutes the majority of the genetic defects. So why Down syndrome has got a lot of importance? Why we should worry about Down syndrome? So Down syndrome, it's a significant abnormality in the population, which I've already mentioned, which happens at 1 in 650 to 800 live births. And these Down syndrome babies, they live for a very long period. It's not that soon after birth they will succumb. They live a full life, 50, 60 years. So when they live for such a long year, the quality of life will be very poor, and there is burden on the family, and social support is difficult to take care of these babies, especially when they're females. Then, especially in developing countries where there is a broken social the impact will be more. They may be sexually aroused because of mentally challenge. So that's the important why these syndromes should be identified when baby is in the womb. So this slide shows photos wherein I have been involved in doing a health camp for an orphanage, wherein this orphanage has got a lot of mentally challenged babies as well as adults. So when you see here, there are a lot of grown-ups where they are diagnosed with Down syndrome. So I have witnessed these people, how difficult to take care of them. So the warden of this hostel was telling that midnight these people keep screaming a lot, then they are very difficult to manage these kind of mentally challenged individuals. So that is an impact on the society as well as on an individual. So what is Down syndrome, and who coined this word Down syndrome? So Down is a person named John Langdon Down. He described the features of the Down syndrome, like physical features. He described that the face of a Down's baby would be flat and broad, cheek is round, eyes are obliquely placed and extended laterally, that is increased intercanthus distance. Then palpebral fissures are very narrow, tongue is long, thick and much roughened, and nose is small. Skin has a slight dirty yellowish texture and is deficient in elasticity, giving the impression of being too large for the body, and thick skin fold. And obviously, mental retardation will be there of varying severity. Then these babies will have heart abnormalities, which the commonest one is AV canal defect. In this bottom right hand side, you're seeing a karyotype wherein 3 chromosomes are seen at 21st location. Next, trisomy 18, Edwards syndrome. The morphological features are more severe compared to Down syndrome babies. So trisomy 18 means there is extra chromosome at 18. So it's called, that's why it's called triploidy. Trisomy 13 is also known as Patau's syndrome, wherein the 13th chromosome, there is an extra chromosome at 13th location. So these are triploidies. That's about the common chromosomal abnormalities. In step 2, we are going to learn about prenatal tests to detect chromosomal abnormalities in pregnancy. So these tests are broadly classified into screening tests and diagnostic tests for confirmation. Under screening tests, you're seeing blood tests. So blood tests, these are called as serum markers, maternal serum biochemical markers, which are otherwise called as double marker, triple marker, quadruple, and pentamarkers. Next modality, screening modality, is ultrasound scan. It could be in the first trimester or second trimester genetic sonogram. And the third screening test is the non-invasive prenatal test. It is called as NIPT blood test. And fourth one is a combination of any of the tests. These are about screening tests. Coming to the diagnostic test for confirmation, these are FISH, fluorescent in situ hybridization, then QF PCR test, then third one is a cell culture. Is a gold standard diagnostic test to common tests. Screening tests are done to find out an individual at higher chance or risk of a health problem in an asymptomatic population. So I'll repeat, screening tests are done to find out an individual at higher chance or risk of a health problem in an asymptomatic population. So screening is done for common problems. Remember this, screening is done for common problems and therefore needs to be applied to a large population. Ideally, the condition picked up should be one where there is some treatment or intervention possible. Third feature of a screening test or a characteristic of a screening test is those who are found to be at increased risk of a condition may need another test to confirm the problem. So screening test is a basic and common test which can be applied to a large population. Coming to the screening in pregnancy is mainly to identify chromosomal abnormalities, genetic diseases, thalassemia, sickle cell anemia, preeclampsia, and inborn metabolic errors. So in this presentation, we are going to learn about screening for chromosomal abnormalities. There are certain factors influencing screening tests. Otherwise, the limitations of screening tests we can tell. One is the detection rate. These terminologies are important. One is a detection rate. So what does this detection rate mean? How many abnormal babies the test can pick up? Example, if we tell 90% detection rate, that means 95 Downs babies detected out of 100 Downs baby. There are 100 babies with Down syndrome. In that, if we tell the test has got 95% detection, means 95 babies or positive cases it can pick up out of 100. Next terminology is false positive rate. A screening test result that shows there is a problem when one does not exist. It is called as false positive rate. That means disease is not there, but the test has showed that there is a disease. What to be done in case of false positive rate or to reduce this false positive rate? A positive screening result should be followed up by a diagnostic test. So what is the impact of this FPR? If FPR is high, then unnecessary diagnostic test the patient will undergo. The next terminology is false negative rate. A screening test result that shows there is not a problem when one does exist is known as false negative rate. That means a disease is there truly, but the test has failed to pick up the disease. It's called as false negative rate. What next? Understand screening does not identify all affected pregnancies. So what is the impact of false negative rate? So it could be a surprise and shock at the time of delivery, isn't it? Because the test failed to detect the problem, the pregnancy continued, and the baby is born. So it would be a surprise and shocking for the parents. So this is about the different terminologies in screening test. So then what's the difference between screening test versus diagnostic test? Definitive diagnosis of chromosomal abnormality is by chorionic villus sampling. It's called as CVS, or by amniocentesis. These both are invasive procedures. Problem with invasive procedure is fetal loss, 1 in 200 to 1 in 800. And 1 in 200 implies that if all pregnancies had amniocentesis, one normal fetus would be lost for every 4 cases of trisomy 21 that are detected, which is not accepted. And diagnostic tests are high cost. So high cost of invasive procedures and diagnostic tests. So they may range, the cost may range between 20,000 to 35,000. It depends upon the expertise and the reputation of the center. Then these invasive procedures needs expertise. Only selected specialist centers can do this procedure. Why do screening tests change or evolve? That's important because it's not the one screening test now it exists means it will not be the same for next 10 years or 20 years. It keeps evolving. Why does that happen? One is to increase the detection rate. If any better tests are there, then these tests are included for the screening purpose so that it can increase the detection rate. Second is to reduce the false positive rate. Third, minimize the invasive testing. Then sometimes some screening tests, they have unreliable serum screening. So those things has to be eliminated. Then unreliable NT assessment can be there. These are the various factors why screening tests change or evolve with period. Then ultrasound and biochemistry are screening tests and they identify the pregnancies that are more likely to have a trisomy 21 fetus and should therefore be offered diagnostic testing. So here you are seeing in this slide the procedures for diagnostic tests. So these two procedures yield material for diagnostic testing. One is amniocentesis. Amniocentesis is a procedure wherein a needle is put into the womb and amniotic fluid is aspirated under ultrasound guidance. So this test is done between 16 weeks to 22 weeks. Second procedure is called as CVS, chorionic villus sampling. Here the needle we are not poking and entering into the amniotic cavity. Here we are just taking the sample from the placenta. So that's why that is chorionic villi. You can see the macroscopic image here. It's a chorionic villus which will be extracted through the ultrasound guidance. So these are the diagnostic tests. So how did this evolve? The screening tests evolved. So this, you can see this bar. So this screening test started as early as 1980, almost 32 years ago. Then over a period of time, that time maternal age was the only thing which was considered to know whether the baby is high risk to have a chromosomal abnormality. Then this alpha fetoprotein has been isolated, and it was observed from that isolated from the mother's blood, and it has been observed that AFP, alpha fetoprotein level, will be reduced in a chromosomal abnormality. Next, in 1987, they also identified that the HCG level goes high, or HCG levels are high in the maternal blood in case of chromosomal abnormality. In 1988, early 1998, double test, that is AFP and HCG, they evaluated. In late 1998, triple test, they added one more protein, that is estriol identification. The reduced estriol was found in chromosomal abnormality. In early 1990, one more component was evaluated, which is called as inhibin. In 1991, they added one more component called as plasma or placenta associated plasma protein A. In 1992, ultrasound came to picture, that is NT measurement. In 1997, the first trimester combined study, that is ultrasound and blood test, was used to evaluate the chromosomal abnormality. So as time evolved, in 2010, by 2011, model of best practice by UK NSC, this has been formulated with 90% detection rate for these screening tests. So let us study what serum biochemical markers are there. So broadly, these biochemical markers are these substrates of either a placenta or a fetus, that is placental substances or fetal substances. From placental substances, the isolates are free beta HCG, then pregnancy associated plasma protein, then inhibin A. These are placental substances. In the fetal substances, maternal serum alpha fetoprotein and unconjugated estriol, these are the isolates from fetal substances. So in chromosomal abnormalities, whether it could be Down syndrome, Edwards syndrome, or Patau syndrome, there is variation, or there are changes in the placental substances and fetal substances. In Down syndrome, what happens? There is decreased fetal substances like maternal serum alpha protein and unconjugated estriol. Remember, fetal components will reduce in Downs, whereas placental substances will increase, that is beta HCG, PAPA, and inhibin. So this is what happens in T21 abnormality. In trisomy 18, all markers are low. In trisomy 13, all markers are low. So that is how we are able to distinguish what risk is high in when we do a blood test, that is biochemical markers. In Turner's without eye drops, all markers are low. In triploidy, that is digenic triploid, all markers are low. So maternal serum biochemical marker tests are done in combination. Okay, if it is double marker, also known as dual test, free beta HCG and PAPA, two component. That's why it is double marker. Two components are assessed. This double marker test is done best between 10 weeks to 14 weeks of pregnancy. Next is the triple test, triple marker test, where 3 components are there: free beta HCG, alpha fetoprotein, and unconjugated estriol. So this triple test is done between 14 weeks to 16 weeks. Third is the quadruple test, where 4 components are there: free beta HCG plus AFP plus unconjugated estriol plus inhibin A, which is this test is done best between 14 weeks to 22 weeks. There is something advanced called as penta test, where only some center, dedicated fetal medicine centers, they advise. So penta test includes free beta HCG plus AFP plus unconjugated estriol plus inhibin plus hyperglycosylated HCG. That is 5 components are there. This test is done between 14 weeks to 22 weeks. So if you see here, double marker, triple marker, quadruple, and penta. So what to do, when to do? So you can see the time period which are done at different time periods. These tests are done. As you add different components, even the cost also increases, but even the detection rate also increases. So we need to balance, or you need to do a fine balance where we can get a maximum detection rate and reduced false positive and false negative rates. In the first trimester genetic screening, the first trimester pregnancy, which is done between 10 weeks to 13 weeks, 6 days. So here, risk calculation is based on maternal age, then the second component based on dual marker, and the ultrasound scan findings. In first trimester genetic screening, as you see here in this slide, see, either maternal age can be considered to detect the chromosomal abnormality. If you add CRL and NT, then the detection rate is different. If you had biochemistry and maternal age, then the detection is different. So there are, in various combinations, these tests can be done, which I am going to explain in future slides. And also I'm going to simplify what exactly when these tests has to be done. So in this table, you can see various factors, that is methods of screening. And in another column, you are seeing a detection rate. And in the next column, you're seeing a false positive rate, isn't it? So we need a highest detection rate as high as possible. And false positive rate should be as less as possible. Let us see, if we consider only maternal age, what is the detection rate here? 30, isn't it? So it is definitely less. Then the false positive rate is 5% in this. If we do a first trimester screening, that is between 10 weeks to 13 weeks, 6 days, you can consider only maternal age plus NT measurement by ultrasound. The detection rate would be 75 to 80%, and false positive is 5%. If you consider maternal age plus first trimester double marker test without any ultrasound, then the detection rate is 60 to 70%. Isn't it? See here, if you take ultrasound, then it has got better detection rate compared to only biochemical markers. Next, maternal age plus first trimester combined test. Combined test means ultrasound plus biochemical markers. Then you get a detection rate of 85 to 96%. Very good. Then if you had some extra additional findings in ultrasound, like detection of nasal bore or tricuspid flow or ductus venosus, still the detection rate increases to 95 to 96%. Now, the standard practice is to do this combined test, that is nasal bone, tricuspid flow evaluation, and ductus venosus, where we could able to detect 93 to 96% chromosomal abnormality. And if you observe here, false positive rate is also 2.5%, which is less, reasonable. This is all in first trimester screening between 10 to 13 weeks, 6 days. Coming to the second trimester screening, which is done between 14 to 22 weeks, if we consider maternal age plus triple marker test without any ultrasound scan, then it is 60 to 65% detection rate. If we do quadruple marker test and consider maternal age, then the detection rate slightly increases, 65 to 80%. If we do integrated test like first trimester NT scan, PAPE and beta HCG plus second trimester quadruple test, then we have a detection rate of 90 to 95%. See, if you see here, combined test, first trimester screening, 93 to 96%, highest compared to second trimester integrated scanning, integrated test like second trimester quadruple test along with the first trimester scan. So what is 100% detection rate? Amniocentesis for fetal karyotyping gives 100% detection rate. Chorionic villus sampling for fetal karyotyping gives 100% detection rate. Fish fluorescent in situ hybridization gives 100% detection rate for chromosomal abnormalities. So that's the importance of various biochemical markers and screening tests at different stage of pregnancy. Next question is, who should be screened? The risk of having a term pregnancy with Down syndrome increases with maternal age. This is known as the maternal age specific risk and is the background risk of Down syndrome used when interpreting a screening. The risk of having a baby with Down syndrome increases sharply after 35 years. However, 70% of the babies with trisomy 21 are born to mothers who are less than 35 because this age group has more babies. Isn't it true? So most of the pregnancies happen less than 35 years. So 70% of the babies born, trisomy 21 babies would be born to a mother who is less than 35 years. So the answer is every pregnant woman should be screened for Down syndrome. Let us see this chart, the maternal age risk factor for Down syndrome. So risk of Down syndrome baby at term by maternal age. So here these columns as we have done the risk stratification as minimal risk, very low risk, low risk, moderate risk, high risk, very high risk. There is nothing called minimal risk. Either it is a very low risk, means whatever age the woman becomes pregnant, there is a risk of giving birth to a Down's baby. Between 20 to 21 year, if the pregnant woman age is 20 to 21 year, the risk is very low to low. 24 to 25 years, still very low to low. 30 also very low to low. 35 also, it becomes slightly, the bar moves towards moderate risk, isn't it? 40 years, low to moderate. 45 years, moderate to high. 49 years, moderate to high. Or sometimes it may go very high. So here, if you see here, this change in the risk happens when the mother's age crosses 35 years. 1 in 250 means if 250 women of 35 years give birth to a baby, at least one pregnancy would be a Down syndrome baby. So this is a high risk group. If you see 45 years, then 1 in 30, every 30 pregnancies will have one Down's baby risk. So every pregnancy should be offered screening irrespective of maternal age. The pitfall, an approximation of the age as is not unusual in India can be confounding. Many of the women or many of the in smaller places, they will not be knowing their exact age. So this mother's age becomes a confounding factor. And what we should consider in case of IVF is a donor age is necessary where appropriate. That is a ovum donor, because that is what determines the genetic component of a baby. That's what should be considered. So when should we begin aneuploidy screening? So already I discussed in the previous slides. To simplify it, ideally biochemistry or biochemical markers should be started at 10 weeks and ultrasound scan at 12 weeks. But 2 times patient has to visit, isn't it? So which is not a good. So it is not a convenient. So for convenience, everything should be done between 12 weeks to 13 weeks. So this avoids 2 visits. That means scanning plus biochemical screening, that is blood test, should be done between 12 weeks to 13 weeks. So that's about various screening methodology. In step 3, we are going to study how to interpret the prenatal test, that is serum biochemical markers. Most of the time, I see when a report comes, it is very difficult for a treating physician or even for a radiologist or for a gynecologist, it becomes difficult to read the report of serum biochemical marker. Let us study how to read a quadruple marker test. So as I already discussed, quadruple marker has got 4 components: free beta HCG, AFP, unconjugated estriol, and inhibin A. And this study is done between 14 weeks to 22 weeks. So now in the report, we see something called as MOM, multiples of median. We don't see this curve, we see this value, MOM, multiples of median. Okay, so in preventive and social medicine, we see this bell curve, isn't it? The central line is called as the median. So if we put so many values or some values, if you put it in this curve, if we plot the graph, most of the numbers will fall adjacent to this median line. Some will go beyond these lines, and very few will go beyond, before this red line and beyond this red line. So these things are called as outliers. So if the values fall within this curve, then it is normal, means majority of the people will fall into this category. These are outliers. Okay, so anything outside 2 standard deviation is called as an outlier. If the value is towards the left side of this median, it is called as less than 0.5 multiples of median, which is significant. If the value is 2 standard deviation away or right side of the median, then it becomes more than 2 multiples of median. So if the values of any biochemical marker is less than 0.5 MOM or more than 2 MOM, that means it is an abnormal value. Let us see this example of a Downs profile report, okay, of a quadruple test. This blue curve indicates a normal individual, normal pregnancy, okay, of a AFP. This is AFP value. This is dimeric inhibin A. This is unconjugated estriol, and this graph represents the HCG. See, this is a median blue curve. Okay, so if you see this point, this is the top of the bell curve. This is a median. If I draw here, okay, then it is going beyond. That is 0. Not exactly less than 0.5, but it is towards the left side of the median. Okay, but not exactly abnormal. So according to criteria, if this median, if I draw a line here, this point is towards the left side, then it is abnormal. Okay, here we'll see this blue curve is a normal thing. Median is here 1. If this is 2 standard deviation, this is 2 standard deviation. If we consider this one, then definitely this DIA is more than 2 standards of deviation, that is more than 2 MOM. Here, this median is towards left side, not less than 0.5, but it is also abnormal. Here, HCG, definitely it is more than 2 standard deviation. So this one and this one is more than 2 standard deviation, DIA and HCG. So these 2 parameters are abnormal. If these 2 parameters are also very less than 0.5 MOM, then the risk would be very higher. So the risk depends upon evaluating the multiples of median. Let us see this real-time sample report of a quadruple test. So this is how a quadruple report test will come. It has got patient demographic like name, patient ID, date of serum taking, then is there any previous trisomy 21, then we got height, then other maternal factors like diabetes, fetus, the number of fetuses, whether smoking history is not there or not, is there or not, IVF pregnancy, and ethnic origin. All these are background maternal risk factors. If anything of this is abnormal or positive, then that also influences the result of the quadruple marker. Here, if we see, these are 4 biochemical markers of the quadruple test: AFP, unconjugated estriol, HCG, and inhibin A. And these values are represented by various international units like nanogram, ng, milli international unit, picogram, something like that. So now it is difficult to assess how much value it is normal or abnormal. That's the reason all these values are matched with a mother who has got similar biochemical background history, age history, everything. Then corrected multiple of median is calculated. Here in this AFP, that is the same graph what we have seen, 0.6 is the AFP MOM of AFP. Then estradiol is 1.1, HCG is 2.09. So this is abnormal. This is an outlier, more than 2 multiples of median. Okay, this is 1.8 inhibin A. So now what happens to the risk? Trisomy 21 risk sampling date is 1 in 275. So if we put this in a bar, in a graph, X versus Y, age is X axis, risk is Y axis. You see this green thing is low risk, yellow demarcated area is intermediate risk, and this brick red color is a high risk. So this is a cutoff, that is 1 in 250. Now at age 29 years, this bar is going up to 1 in 275, which is intermediate risk or moderate risk, we call it. Okay. So next, what to do if there is intermediate risk, which I am going to explain in the future slide. So this Down syndrome risk, this tells us the calculated risk for trisomy 21 is below the cutoff. The cutoff here in this lab is taken as 1 in 250, which represents a low risk. After the result of the trisomy 21 test, it is expected that among 275 women with the same data, there is 1 woman with a trisomy 21 pregnancy and 274 women with not affected pregnancy. So this is what the screening reports say. Out of 275, 1 can be affected, not all the babies. So the calculated risk by Prisca, this is a software name, depends on the accuracy of the information provided by the referring physician. Please note that risk calculations are statistical approaches and have no diagnostic value. So this has to be taken into consideration. And this also gives a risk for neural tube defect. That is, AFP is a marker for neural tube defect. All right. So this is about quadruple test sample report. Green is below cutoff, then yellow is above cutoff, and this is also above cutoff. So this is about the interpretation of the quadruple marker. Double marker also will be on the similar line, which I'm going to show an abnormal double marker report. So coming to the first trimester screening ultrasound scan, which is commonly done nowadays. Earlier, only one scan used to be done at 5th month, but nowadays, no matter what the socioeconomic status, the scanning starts at first trimester of pregnancy. So you are seeing this person, Professor Kypros Nikolaidis. He is the pioneer of fetal medicine, and he introduced this screening system by ultrasonography. How did the evolution of ultrasound started for screening purposes? So different screening tests are offered at different times during pregnancy. Earlier, when it all started in 1990, 20 to 22 weeks anomaly scan was done. Along with that, second trimester genetic sonogram, that is, some soft markers were evaluated to identify the genetic abnormality. Later on, what the Kypros did is, he said that we can prepone the scanning, that is between 11 weeks to 13 weeks, 6 days, and we can assess nuchal translucency and nasal bone, that is NTNB. Then followed by one more scan, which can be done at 20 to 22 weeks for anomalies, that is morphology. And along with that, we can evaluate some soft markers for genetic abnormalities. Then over a period of time, he said that one more additional scan which can be done, which is called as dating scan, between 6 weeks to 9 weeks, followed by 11 weeks, that is NTNB scan, plus an anomaly scan which can be done between 20 to 22 weeks. And as clinically necessary, further any other scans can be done. This is how it involved. So now the standard practice is dating scan between 6 to 9 weeks, 11 weeks to 13 weeks, 6 days, NT scan and anomaly scan at 5th month. Coming to the first trimester ultrasound, which is done at 11 weeks to 13 weeks, 6 days. This is we call the patient to come between 12 to 13 weeks. Reason being, in 11 weeks, if we do the scan, sometimes the scan machine resolution may not be as good. As the higher end machines can pick up the resolution of NT scan and it can give the NT value, but in a low platform machines, it is very difficult to assess the nuchal translucency, thickness and nasal bone at 11 weeks. That's the reason at 12 to 13 weeks would be an ideal time to call the patient for NT-NB scan. So now this NT scan is considered as a first trimester screening only if the crown rump length is between 45 millimeter to 84 millimeter. If it is less than 45 millimeter, accuracy will not be there to measure the NT and NB. If it is more than 84 millimeter, then also the accuracy reduces. Not that it cannot be considered, but the accuracy, the study what they have done, the detection rate is high between 45 millimeter to 84 millimeter. That is the reason within this window, the NT scan has to be considered. Okay, this crown rump length only a person who does the ultrasound will know, but patient will not know whether my baby is 45 millimeter or 84 millimeter. That's why we should call them between 12 to 13 weeks. Then we assess nuchal translucency, nasal bone, ductus venosus waveform and pulsatility index, tricuspid regurgitation we check. Above 4 parameters are aneuploidy markers. 4 parameters: nuchal translucency, nasal bone, DV and tricuspid regurgitation. Additionally, we look for fetus structure for any anomalies even in first trimester ultrasound. So we know that first trimester ultrasound is between 12 to 13 weeks. That is screening test. So now certain techniques has to be followed to consider for a prenatal screening, because many a times the quality of image may not be good to qualify the scan for first trimester screening. So there are certain criteria for good NT scan. As I already mentioned, CRL between 45 millimeter to 84 millimeter, a good mid-sagittal view to check the CRL, that is crown rump length we call it. Then the head of the baby should be in neutral position. See here, this is a chin, this is a chest wall. This gap should be there to tell it is in neutral position. Sometimes it will be flexed or too much extended neck. It will alter the value of the nuchal translucency. Only in head and upper thorax should be covered in the image, means zoom should be optimum. Then caliper movement of 0.1 millimeter should be there. See, this is what I have measured, NT, nuchal translucency, black line, okay. This black line, this is a criteria is there to assess. So caliper placement along the inner echogenic line, white lines of the nuchal translucency. So all this needs little bit of skill and a good technique to capture the good images. So first trimester ultrasound, how do we interpret? So normally NT means nuchal translucency. This is a small black dark space, okay, behind the neck. So earlier days, anything more than 3 millimeter NT thickness is considered as abnormal, but it's not like that. NT thickness varies with length of the baby. Up at 45 millimeter, normally 1.2 to 2.1 millimeter is the value of the NT. At 85 millimeter, 1.9 to 2.7 millimeter is a normal NT value. See here, 40 millimeter CRL length, 50th centile is 1.2, 95th centile is 2.1. So if you see at 45 millimeter, if the NT thickness is more than 2.2, then it is abnormal. In 85 millimeter, if it is more than 3 millimeter, it is abnormal. So this is the median value. This is how it should come. So this is the interpretation of nuchal translucency. Quality of scan is very important. As I mentioned, this is a poor image because neck of the baby is turned to one side. So it is not a good way to measure the nasal bone. So here it's a good image. You're seeing a nice nasal bone here and a good nuchal translucency. Abnormal nuchal translucency. This is an example of abnormal nuchal translucency. A significant number of normal fetuses have a thickened NT. A pregnancy should never be terminated on the basis of this finding alone. It's very important. I will show you why. Second component is nasal bone. See, you see here equal sign. This is the skin of the nasal bone. It is not a nasal bone. Skin, tip of the nasal nose. Here, this is the skin. Below that is the nasal bone. So this is how a good nasal bone should be seen. It's a nasal bone. Okay. So either the abnormality is when there is this nasal bone is not seen. That means it is hypoplastic or delayed ossification. It is one of the marker for Down syndrome. Third component in ultrasound is ductus venosus waveform. So ductus venosus is a small blood vessel. Okay. So it's seen in the abdomen. 80% of trisomy 21 fetuses will have abnormal DV waveform. 5% of normal fetuses will have abnormal DV waveform. If it is abnormal DV, then it should not be that it is a trisomy 21. In 80% of cases only it is abnormal DV. Abnormal DV, this is normal ductus venosus flow. Okay, forward flow we call it as. In abnormal DV, it will have a reduced forward flow and a higher PI. This is called A wave. A wave is absent. It is touching the base form. Here A wave is much higher. Okay, absent A wave or reverse A wave. Both are abnormal. And why this DV would be abnormal is DV is directly connected to the right atrium. So in Down's babies or in any chromosomal babies, if they have heart defects, then there will be abnormal waveform velocities, and those pulsations will be transferred to the ductus venosus. That's how the waveform also changes. And it should be remembered that ductus venosus waveform is an independent marker and it requires skill and time for assessment. Means an experienced sonographer we can pick up the good waveform. Fourth component is tricuspid regurgitation. Tricuspid regurgitation, that is tricuspid valve regurgitation. If we check the 4-vessel heart, if we put the cursor across this tricuspid valve, then there will be backward flow because there will be defect in the tricuspid valve. So that's why there would be tricuspid regurgitation. And if at all there is increased nuchal translucency and abnormal tricuspid regurgitation, then we can tell that this baby is have a high risk for Down syndrome. Okay, and there is standard criteria to assess tricuspid regurgitation, like there should be apical 4-chamber view and 3 to 4 millimeter. The gate volume should be there. Then the regurgitation, that is half systole, it should be assessed. Then if the regurgitation velocity is more than 60 centimeter per second, it is abnormal. At least 3 readings should be taken. So this is a normal tricuspid flow where regurgitation is not that much. Here you can see a high regurgitation. Nuchal translucency, you need to know that there is no association between thickened NT and biochemical parameters. These should therefore be combined to enhance detection rates. I will show this case, which is interesting. In this case, we have measured this nuchal translucency, which is coming at 3 millimeter. 3 millimeter, you can see definitely this is a thickened NT. Okay. Although this doesn't qualify for first trimester screening because CRL is just 36 millimeter, but nuchal translucency is increased. So this baby, we waited till 11 weeks and the double marker study was done. Double marker study, trisomy 21, low risk, that is 1 in 6,959. Trisomy 18, 1 in more than 1 lakh. Trisomy 13, also more than 1 in 1 lakh. So all are low risk. So what to do? But thickened NT. Next, we followed up. Patient came back at 13 weeks. In 13 weeks, as you see here, this is little bit extended. Here you can see this, that nuchal translucency has become normal. That is, it is 2 millimeter now. Earlier it was 3 millimeter. Now it is 2 millimeter, means it is reducing. Okay. So this is done at 13 weeks, 6 day. So we didn't want to take chance. So NIPT, no, not NIPT, microarray, its amniocentesis was done at 17 week, 1 day. Because once we tell nuchal edema, like even this baby had choroid plexus cyst, so the patient didn't want to take any choice. Even gynecologist didn't want to take any chance. So we did a amniotic fluid analysis for karyotyping. Here, trisomy 21 Down syndrome negative, trisomy 18 negative, all other chromosomes negative. Okay, so we did the anomaly scan, no obvious fetal anomaly, nuchal fold thickness has become normal in this baby. Then there is complete resolution of choroid plexus cyst. Interesting, isn't it? So this we followed up. This baby was born at term and it's doing good. I mean, the learning point is, although nuchal translucency is thick, we need to follow up with, and we need to do appropriate diagnostic tests to confirm whether chromosomal abnormality is there or not. Case 2. Here also nuchal translucency is 2.8 millimeter. The scan was done at 13 week 3 day. Increased nuchal translucency. When we plot the graph, it was coming more than 95th centile. Nasal bone was seen, ductus venosus flow is normal, no tricuspid regurgitation. What to do next? See, risk estimate for NT and NB is 1 in 3,316. If we consider only NT risk, it is 1 in 995. That is intermediate risk. The risk between 1 in 250 to 1 in 1000 is called as intermediate risk. Then we did double marker study. Double marker study is showing this, see this black bar, it is stopping here at 1 in 250, isn't it? It's an intermediate risk, 1 in 249 it is showing. We did a NIPT, low risk for chromosome 21, 18, 13 and 6 chromosomal aneuploidies. Then followed up at anomaly scan, she came at 20 weeks, 5 days, nuchal fold thickness has become normal here. Okay, then we followed up further, 32 weeks, we did the scan, everything was normal. So this baby was born normal. So that's another case which tells that abnormal NT doesn't always mean that there is chromosomal abnormality, which it has to be followed up with proper diagnostic test. Now, I've been telling risk, risk, risk. What is this risk? A risk is the chance of an event occurring. Down syndrome of 1 in 100 means that 100 women have this test result. We would expect that one of these women would have a baby with Down syndrome and that 99 would not have Down syndrome. This is the same as 1% chance that baby has Down syndrome and a 99% chance that the baby does not. And patients and caregivers may not understand the risk. If we tell 1 in 250, 1 in 350, then they don't really understand. What I usually do is I may give a real life equivalent. Like if you are crossing a road, if the road is empty without any vehicle or with few vehicles, then the chance of you getting hit by a vehicle is less. When it is a busy traffic, if you try to cross a road, then the chance of you hit by a vehicle is high. That is high risk. So that's how it is. Probability is can be either ways. You may miss it or you may get hit. That's what the risk is. Higher the risk, then you need to consider diagnostic test to confirm. That is about step 3, how to interpret the results. Step 4 is the management, counseling and decision making with risk group and cutoffs. Now the report has come. So you have the report telling that it is high risk or low risk. What next? When we consider high risk, this is a new criteria. When the pregnancy risk or the biochemical marker risk is 1 in 10, it is high risk. Definitely you should advise invasive testing like amniocentesis or CVS. When the risk is more than 1 in 50, still it is high risk. Advise an NIPT. NIPT, I'll tell you what exactly is NIPT. Advise NIPT or invasive testing. 1 in 50 to 1 in 999, it is called as intermediate risk. Then in intermediate risk in biochemical marker, then assess nasal bone, ductus venosus, tricuspid regurgitation and recalculate risk or consider NIPT in such case. When the risk is less than 1 in 1000, it's called low risk. Then you call her for a routine second trimester scan with genetic sonogram. Then we have this sample reports of double marker test. Quadruple marker I showed. This is a double marker test. This is how it comes. Okay. So we have patient demographic here: age, height, weight, then maternal factors like diabetes, hypertension, all these things we have. Then scan also is included here. CRL length has been mentioned. Scan gestation age, 12 weeks, 6 days, that has been mentioned. Here we have a biochemical markers like beta HCG and PAPE. So it is showing, see, the corrected MOM is 2, which is abnormal. PAP is 1. All right. So here what happens to the risk? Age risk for T21 is 1 in 685. Low, intermediate, or high? So I told you between 1 in 250 to 1 in 1000 is intermediate risk. So this is intermediate risk. All right. Age risk is intermediate. Risk value is 1 in 1221. So this is a low risk, it has been mentioned. Age risk and the risk value by biochemical markers. All right. So all are low risks here in this. So it is screen negative. Another report, quadruple marker, 4 parameters here, then corrected multiples of median here. Okay, this is low risk. It's in the green zone. T21 risk, 1 in 1359. Second report, intermediate risk, 1 in 275. So single or combined markers. It is standard practice to interpret a Down syndrome screening test by calculating the risk of an affected birth from the maternal age, family history, and marker profile. Women having separate NT and serum screens are often given 2 risks, and if they differ, this can lead to confusion and avoiding anxiety. It is not valid to simply take the average of the 2 risks. So only 1 risk has to be given. So this I have already shown you this table. Highest detection rate is for combined test, that is blood test along with NT evaluation along with nasal bone, tricuspid flow and ductus venosus flow, 93 to 96%. Coming to non-invasive prenatal test, what is this? This is a maternal blood test, wherein cell-free DNA from the placenta, it is believed that it will be circulating in the mother's blood. So this we are going to take out, the mother's blood is taken out, and this cell-free DNA will be studied in the lab. And NIPT should be done after 10 weeks of pregnancy. The detection rate of NIPT to detect Down syndrome is 99%. It's not 100%. False positive rate can be 0.1%. What is the drawback of this NIPT? Sometimes there won't be result in 5% of cases because of less fetal fraction which is circulating in the mother's blood, or when there is poor placental function, then also we don't get free DNA. Then in obese mother, the plasma volume will be high. That's why there is dilution. So we don't get a good fetal fraction. NIPT is never done alone. The test is always followed by other serum markers. It's an expensive test. People do a different price range, but the thing is, it depends upon different methodology of testing the cell-free DNA. That's why the cost varies from lab to lab. And this NIPT is less sensitive for trisomy 18 and 13. So if there is strong indication for chromosomal 21 abnormality, then NIPT is suggested. See how to go about this NIPT. Here, this is how the report of NIPT comes. Okay. See this. The chromosome 21, 18, 13, low risk, low risk. For 13, high risk. Further investigation recommended. This is what it shows. Okay. If first do combined test. If the risk is high, then request NIPT. There may be low fetal fraction or no result in NIPT, then it becomes inconclusive study. Then advise invasive test or quadruple test in such case. So what we should know is if NT is more than 3.5 millimeter or there is fetal structural abnormality in ultrasound, no, don't do NIPT because there may be other chromosome abnormality or there may be other genetic syndrome which has to be evaluated by amniocentesis or karyotyping. So NIPT doesn't give good report in structurally abnormal baby. So advise amnio in such case. And why ultrasound scanning when NIPT has high detection rate of 99%? So the intention of first trimester screening is to detect chromosomal abnormality. Then we can say scanning can be avoided, only blood test can be done. No, it can't be. Scanning has advantage. Scanning has advantage of to date the pregnancy, to confirm viability and number of fetuses, maternal pelvic pathology, to detect fetus structural defects, and to screen for aneuploidies. Let's say we take NT, NB, DV, and TR measurement. Then preeclampsia screening can be done with ultrasound to detect FGR, that is fetal growth restriction, and preterm labor. Certain fetal structures which can be seen, which should be seen in first trimester scanning. These are, let's say, see in this image, we are seeing a nice nasal bone. We are seeing a good spine here, umbilical vein, stomach, hand we are seeing. We are seeing cord inside eyes, both eyes. We are seeing kidneys, diaphragm, stomach. We are seeing the leg. We are seeing umbilical cord insertion. We are seeing the spine. So in first trimester scan, there are certain abnormalities which should not be missed. Means it can be diagnosed. You might miss because of very tiny structure, and you're going to miss this structure. And if we do scan between 10 to 13 weeks, there are conditions which should not be missed, like in brain anencephaly, holoprosencephaly, large cephalocele, cystic hygroma, like that in face, chest, abdomen, spine, extremities. So like that, early ultrasound scanning gives information on some structural abnormalities. So there are terminologies like likelihood ratios or soft markers of the chromosomal abnormality. These are cardiac echogenic focus, ventriculomegaly, increased nuchal fold thickness, echogenic bowel, hydronephrosis, short humerus, femur, aberrant right subclavian artery, absent or hypoplastic nasal bone. See, if these features are there, then the detection rate of chromosome increases. False positive rate is also there. But the likelihood ratio, if you see here, ventriculomegaly, increased nuchal fold thickness, ARSA, that is aberrant right subclavian artery, absent or hypoplastic nasal bone. These parameters has got highest likelihood ratio that the baby might be having chromosomal abnormality. In such cases, further studies has to be done. It should not be stopped there only. So second trimester genetic sonogram, we have certain features like absent nasal bone, aberrant right subclavian, increased nuchal fold thickness, echogenic focus in the heart, echogenic bowel, ventriculomegaly. These are also the indicators for chromosomal abnormality. Some cases where we could identify abnormalities in first trimester, like fetus acrania, absent cranium, which is a lethal anomaly. Okay. Then we got this holoprosencephaly, single monoventricle is seen. Okay, large head. So these are detected as early as 12 week 4 days. That's why it is important to do ultrasound as early as possible to reduce the burden. This one has got anencephaly malformation. Okay, this has got this one was interesting. I could not usually normally these hands and digits are well seen in first trimester sonography because hands the fingers will be open, so you can count the digit as well compared to other second trimester and third trimester scan. So here I could not see the hand of the left side, so I did 3D scan. So left hand was absent. Okay, absent left hand of the most likely amputated by amniotic band. And this scan was done at 11 weeks 6 day, wherein the entire heart and abdomen structures was outside the abdominal and thoracic cavity. Okay, so this is a pentalogy of Cantal abnormality, which was detected as early as 12 weeks. So when screening not required, patients who request for direct invasive testing means they tell I don't want screening, I want baby is normal or abnormal, then don't ask for screening. Ask for invasive testing like fish or carrot. Then patients who will not terminate for religious and other reason, why you want to screen in that babies? Even if it is abnormal, they are not going to terminate. In such cases, screening not required. So to conclude this presentation on first trimester screening, Down syndrome can be diagnosed during pregnancy. Diagnostic tests are invasive and have an inherent miscarriage rate. However, the risk is small. They are also expensive. Screening tests can identify a large number of patients who would benefit from diagnostic testing, thus reducing risks and costs. Screening tests, by definition, cannot identify all affected pregnancies. Diagnostic tests are required to confirm. First trimester screening is more effective than later trimester screening. So what a prenatal screening program does, that is the roles and responsibilities are, for an obstetrician, you should advocate universal screening for every pregnant woman. Ensure that the tests are done with appropriately certified personnel, because NT-NB scan needs certain skill to do the study. Okay. Then provide feedback regarding the outcomes of the pregnancies that have undergone screening. Coming to radiologist, sonologist, or fetal medicine specialist, perform the scan as per standard in every patient. Enroll in FMF, that is Fetal Medicine Foundation Competence Certification Program. Third, for the laboratory, perform tests using approved equipment and kits. Periodic replotting of medians must be done. Participate in external quality control program on an ongoing basis. So this already I mentioned. The risk group and cutoff, this has to be kept in mind. So a good prenatal screening structure is a teamwork between a radiologist or a sonologist, obstetrician, and geneticist. So thank you for watching this presentation. If any doubt regarding any of the content, you can reach me at sunilkumar@addonhealthcare.com. So I'll stop this presentation. Hope this presentation you found it useful, and you can go through repeatedly this presentation, and yeah, so that's how we can improve our skill and knowledge by repeated learning. Thank you for your time once again. Thanks a lot.